now we are going to move into the main event for today. Dr. Lightfoot, are you with us?
Yes, I am. Yep.
Perfect. Okay, well, I'd like to formally introduce Dr. Lightfoot. He's the psychologist with our Indianapolis VA palliative care team. Um, so before we start, I'll share a little bit about his role. Dr. Lightfoot specializes in palliative and hospice care and provides services to veterans, their families, and caregivers. As I said, he works with the Indianapolis VA palliative care team, and he serves veterans who are admitted to the hospital, as well as those seen in our outpatient clinic and in the community. He works with both our inpatient and outpatient teams. He also coordinates and provides care to veterans who are in the community on hospice and/or at nursing facilities. Dr. Lightfoot previously served as a part of the Indianapolis VA PTSD clinical team, and he carried this interest forward in his work with palliative and hospice care. So we're very lucky to have a psychologist full time with our team who specializes in PTSD, moral distress, and end of life care. So thank you so much for being here, Dr. Lightfoot. And with that, I will stop sharing my screen and let you share yours.
Okay. Let's see. I'll hit present. Uh-oh. Oh, here it goes. Okay. Technology and I don't always get along, so let's see if
There
this
you
will
go.
actually work. All right.
Yeah,
Can you
looks
guys?
good.
Okay, good. Excellent. All right. Well, first off, let me start off by thanking you guys for letting me present here today. It's very nice to be able to be a part of this group. Also, I want to thank you for the kind of work that you are doing as we move forward and talk about some of these things. One of the points that I make is that at the VA, we really get to only work with and try to treat a very small percentage of the overall number of veterans in the state of Indiana. And so you guys out there are taking care of a lot of our people. So I really appreciate that as well. I guess sort of the final thing is my cat got me up at 4:30 this morning. So if I suddenly go silent, I've probably fallen asleep. Somebody just wake me and we'll start moving forward again. Okay. Anyway, with that excuse out of the way, let's talk a little bit about PTSD and moral injury. So there are some objectives for today's presentation. First off, I'd like us to be able to talk a little bit about PTSD and some of the signs that are involved, how this can impact people, veterans in particular, at the end of life. And then talk a little bit about moral injury and how PTSD and moral injury have some similarities, but also some differences. And then finally, talk about a tool and sort of a methodology to try to identify when these are going on, to assess them a little bit, and most importantly, to be able to palliate some of the things that go along with moral injury and PTSD. I think we should be able, if people have questions as we go along, they should be able to come off mute and just kind of let me know. Or we can do questions at the end. But I would say if something's unclear, if you have a question, just pop in and let me know as we go along. Okay. So let's start off with a little bit of history here. So we're going to focus mostly on Vietnam veterans today, which seems appropriate after we just were talking about some of the special features of thinning ceremonies. Um, but this will apply, more broadly to other veterans as well. I mean, it's hard to believe, but like the first Gulf War was over 40 years ago now. So um, lots of people post-Vietnam are going to be coming in and we'll be serving them as well. But let's start with this focus. So nearly 3 million Americans served in the military in the Vietnam War. About 58,000 lost their lives. But for those who returned, the war really continued in a very different way. Many came home to a different kind of conflict and found that home was not really what they expected. Um, I have had so many people tell me that when they were over there, all they thought about was getting home. And then when they got home, they kind of wished they were back over there because they didn't seem to fit in any place. Now, this wasn't true for everybody. I mean, the majority of returning veterans made their way through life. They had families, got jobs, who had all of those kind of things. but many carried their experiences with them. And they did this in ways that have resulted in medical, psychological, and spiritual problems that influence their ability to sort of interact with us and care at this part of their lives. If we think about it, at this point, nearly all of our veterans, our Vietnam veterans, are over the age of 70. Um, as I can confirm myself, with age comes a host of difficulties. But for this group, these challenges are frequently made even larger by the presence of PTSD and moral injury. And again, here at the VA, we have resources to help. But a majority of seriously ill Vietnam veterans receive care outside of the VA system, making intervention difficult and the need for outreach very significant. So let's talk a little bit about just the idea of trauma. So trauma in and of itself is not a new idea. In writings as early as the Iliad, the history of the Peloponnesian War, the effects of battle and trauma on individuals were noted. Major conflicts in the 18th century, such as the 30 Years' War, gave rise to the concept of nostalgia as these overpowering emotional symptoms were seen and described in some soldiers. In fact, it's interesting, when I was looking at some of this, people would actually be sent home, right? And they would go and spend some time with their families and sort of get rejuvenated and then go back and fight again. So the idea of sort of R&R way before R&R ever existed. During the Civil War, more physical and panic-related symptoms were noted and were called soldier's heart to sort of reflect this physical side of the psychological effects of battle. And then, of course, World War I famously gave rise to the term of shell shock, which became battle or combat fatigue in World War II. And then eventually, because we like to make things much more complicated, post-traumatic stress disorder or PTSD after the Vietnam War. So in a broad way, the way that we see PTSD has traditionally had a lot to do with when we're talking about it. So basically, the consensus has been that during times of war, such symptoms are a sign of weakness that frustrates the need to have soldiers on the front lines. However, after the war ends, there's room to recognize the effects of war, and we see it as something deserving of treatment. I think, when I stop and think about it, I think movies are a really great reference for this. And I don't know if any of you guys have seen these, but there's an incredibly famous John Wayne movie called The Green Beret. And I've actually had veterans tell me that they signed up because of the power of this movie and how inspiring it was to go off to war. Versus movies that were made after Vietnam, such as Coming Home or The Deer Hunter, where they were these very deeply exploratory movies looking at the effects of combat on people as they've come back to the real world. So let's start to talk a little bit then about PTSD itself and how we think about it diagnostically. So PTSD is a disorder resulting from exposure to actual or threatened death, serious injury, or sexual violence that can arise from a variety of different events. Many of these are not combat related, and it's quite possible for individuals to have had trauma either prior to their service or after their service. Uh, so it can arise from a lot of different kinds of settings. Two prominent ways to look at PTSD are either as sort of a completely normal reaction to non-normal situations, or as a failure of the normal recovery system to cope with just an overwhelming problem. In either case, the reality is that patients have an altered ability to manage their distress in ways that affect their lives and our ability to care for them. So if you think about that trauma affects our ability to cope, our ability to manage, the military wanted to weed out those people who are most likely to quote unquote crumble under the stress of combat. And so there were a whole series of studies done to try to identify, the quote unquote weak ones. And what they found was when they looked at, hair color, eye color, height, weight, gender, a whole bunch of these different kinds of factors, none of them made any difference whatsoever. None of them mattered at all. The reality is that we all have some degree of ability to deal with distress. And we also all have built-in limits to that ability. Therefore, anyone can develop PTSD. So diagnosis of PTSD relies on two criteria. The first is there has to be an identifiable criterion event. Now, sometimes people have experienced more than one traumatic event, and so it's important to sort of understand the relative impact of each one. So this could include things like directly experiencing or seeing something, even learning about a violent or unexpected death of a friend or a family member, or experiencing repeated or extreme exposure to details of traumatic events. So sometimes it can be that kind of thing. Also, a person may be trapped in an environment where the stress is inescapable. So something that we see sometimes in military settings is maybe sexual abuse in a unit or on a ship that people can't escape, they can't get out, and they can't report it up because that reporting stream may well be part of the problem as well. So there are multiple ways that people can come into contact with these kinds of events. So once that we've established that a criterion event has occurred, the next thing that we look for is basically symptoms that arise from this. So a combination of symptoms from specific symptom clusters are necessary. And you can see here we have re-experiencing, avoidance, negative alterations, and hyperarousal. And so re-experiencing symptoms, are things like nightmares, flashbacks, negative alterations, can be problems with remembering certain aspects of events, depressive or explosive episodes. Hyperarousal has to do with the idea that these guys are just always wired and ready. Any little sound can set them off. These are people who are really paying too much attention to what's going on in the environment. And avoidance, well, we'll talk about avoidance here, but the key is that these need to be present for at least a month, and they have to cause a significant level of distress or impairment. Okay, so I left avoidance aside because it's a really important part of this. And in the end, it's really just a way for people to stay away from triggers and reminders, right? Unfortunately, it's also the gasoline that just fuels the engine of PTSD, as one of the primary things that avoidance does is it drives withdrawal. And when people withdraw from the world, they end up being left with nothing but their memories and their symptoms. So avoidance simply is staying away from thoughts and feelings by staying away from people, places, activities that prompt memories. And because of this, people become detached and can lose any sense of life beyond escape. So PTSD in some ways can be thought of as a situation where the memories or the effects of an event can almost overtake the actual experience of the event. And that's, I'm not trying to downplay what occurs with people, but what can happen in several ways is a great deal to do with the patient's perceptions of themselves and the world around them. So the reality is in moments of crisis, we have to make decisions, right? And often there are really no good choices. And this is even more true in combat situations or in very high stress situations. And one of the most fundamental things to understand is that all of us are wired for survival. One of the most deeply held things inside of all of us that we never think about, never evaluate, is that we try to live, we try to go on. And because of this, we can end up making choices that allow us to survive, but they can also be situations that are very hard to live with. So I think, for me, a really good example of this, oh man, it's been a long time ago now, but my wife and I went hiking in Canada and there were lots of bears up there. And so you carry bear bells with you and all these things because it ends up that bears are not a big deal. It's surprising bears that's a big deal. So anyway, let's say that all of us get together and decide that we're going to go on a hike. And we take off and we're hiking through the woods. And for whatever reason, we come around a corner and we surprise a bear. The bear doesn't like that and lets us know that he's not very happy. So the question here is, do I have to be faster than the bear? Well, the answer is no. Obviously, I don't. I just have to be faster than you, right? But let's say that I'm not the fastest. In fact, maybe I'm the slowest person in this entire group. But I want to get home. I have a family. I have a life. I have as much right to get out of this as anybody else. So I trip you. Down you go. The bear jumps on you, and I get to run away. Get to the edge of the woods, standing there with everybody else, panting, hands on knees. What happened to that other person? I don't know. Something must have happened, but they didn't seem to make it. Okay, so I was able to get out of this. I survived, but there's a really good chance that out of this, I'm going to be asking questions about myself, and I can end up with these changes in how I perceive myself. And the beginnings of guilt and shame and self-blame can start to lay down elements that will eventually become decisions and choices and beliefs of things like, it's my fault, I failed, I could have, I should have, or even perhaps something like, I'm a monster. So perhaps even more powerful than the physical effects are changes in how people may see themselves after trauma. Trauma can leave people feeling that they're damaged or broken, that they're to blame, and that no one can understand, meaning that they're all alone in this world, and perhaps they don't even really deserve to feel better. This isolation and blame can provide a giant field where the effects of damage from trauma can just grow and grow until everything else is obscured or lost. And so what ends up happening is that we're simply different than we were before. But it's not just us. The other thing that changes is the world, and the world is no longer to be trusted. People are evil. You can't trust anybody. They'll hurt you if you give them the chance. The world is a dangerous place, and if I'm not careful, all of this is going to happen again. And so no easy refuge is found, and all of this leaves me in a position where the best thing I can do is run in a corner and be hypervigilant, right? Be ready, but be on my own. So I hope that from that you get some sense of sort of the mindset, the feelings, the kind of experience that people with a significant trauma history can come into situations with. Um, Now what I'd like to do is to try to build a similar kind of image, but more from the perspective of moral injury. So as we begin to talk about this, I think it's important to understand that the concept of moral injury is relatively new, especially compared to the idea of trauma and even PTSD. And that in terms of it being sort of a stimulus for specific research or treatment modalities, this is really not that old. So there's not nearly the same sort of bank of research and literature to turn to. Um, and while some of the key ideas like guilt and shame in relation to wartime experiences have been written about for centuries, it's really only in the last decade or so that we've started to really apply sort of an evidence base and a research perspective to try to understand how all of this stuff clicks together. And that really, in ways, allows us to more accurately define it and begin to effectively understand and treat moral injury. So what is it? What is moral injury? Well, there are lots of different definitions. One that I like is I think fairly straightforward. Basically says that events are considered moral injuries if they transgress deeply held moral beliefs and expectations. Um, Guilt and shame have been noted in many research studies related to PTSD, and to the degree that even the DSM includes guilt as one of the core components of PTSD. And research indicates that guilt is common following trauma and combat, and that it can exacerbate post-traumatic stress, and that it often persists without treatment. Uh, Guilt and shame as the core elements of shattering one's sense of self as a moral being is really sort of at the heart of what we're talking about with moral injury. And I think for me, probably one of the best ways to think about this or to sort of picture it is I get this sense that sort of inside of each and every one of us is a little, almost like a glass onion. And it contains this sense of who and what we are as moral beings. And this is started to be laid down when we're very young. You know, there are people around us, parents, family members, different institutions, groups, friends, and they each sort of lay in these subtle but powerful flavors of what it means to be a good person or a bad person. And we kind of go through this thing of figuring out, oh, okay, well, these are the things that are important to me. And even though it's not really necessarily a conscious process, we end up with a structure inside ourselves that says, this is what it means to be a good person. And that's part of what drives me to be who and what I am. But sometimes we can find ourselves in situations where we're forced to act in ways that are so inconsistent with that little glass onion, that little glass apple, whatever it is, can be shattered. And we feel that we've lost that sense of what our moral center was. And much like Humpty Dumpty, even if we can find some way to put it back together again, it's not what it was before. And so we now see ourselves as somehow flawed or somehow different than we were before. So when we start to think about this, Vietnam veterans have some unique risk factors that are important to be aware of. One of them is the social burden of reintegration, and this sort of code of silence that was created. So people got back from Vietnam, they were handed a packet of back pay, maybe a bus ticket or an airplane ticket, and essentially the message was, shut up, get married, get a job, go away. And in fact, I've had many different veterans tell me that they thought that the VA was only for people who'd lost a leg or an arm, they didn't think it was a place for them. And so they just had to kind of go off and deal with things the best they could. Well, Vietnam veterans returned from their service to a society that was angry about the war. And so they didn't get to come home to a hero's welcome because this anger was also put on the people who fought the war instead of the people who directed it. And so out of this grew this idea that nobody understands what I went through, nobody cares about what I went through, and this code of silence formed around service in Vietnam that basically didn't allow any kind of escape valve for the thoughts and the feelings that people were carrying. And when I can't talk to you about what I'm thinking, when I can't talk to you about what I'm feeling, there's no chance for me to say something and have you go, well, okay, I get that, but that doesn't sound quite right. There's no sounding board, there's no echo, there's nothing coming back at me to challenge that. And so over time, those become beliefs. And the missing parts and pieces that were lost when my sense of who I am as a moral being was shattered. Well, now they get some new additions to help make it more complete. But these are beliefs that basically reinforce that idea that I'm flawed, that I'm broken, right? There were also many unique health exposures that had an impact on the aging process for Vietnam veterans, things such as Agent Orange, immunizations that they went through, and of course, once they came home, alcohol and substance abuse, stress-loaded occupations, different kinds of social behaviors. So there were no services waiting. They were met with dismissal, a feeling of rejection by the government that they fought for, a sense of rejection and misunderstanding from the people that they thought they were fighting for. And so many people had these mixed feelings about their service and their identity as a veteran. And because of that, many have refused to engage in seeking health care at the VA, again, making the role that you guys have all the more important. So as I'm presenting this, it sounds like moral injury and PTSD have a lot of things that make them alike. And the reality is they do. As this slide illustrates, there really is a pretty significant overlap between the two. But there are also some ways to distinguish. So first off, moral injury is far less likely to be related to life-threatening events and tends to have more to do with a sense of spiritual and identity focus, right? There's less research, as I mentioned, less consensus on definitions. But in the end, when I'm talking with somebody and I'm really trying to understand the role of trauma, I'm really looking at this sense of directionality. So in moral injury, what I'm hearing from somebody is, I am broken, I am dangerous, I am unforgivable, I am unredeemable. In PTSD, what I'm hearing is, the world is broken, the world is dangerous, and the world is irredeemable. So this sense of directionality has a lot to do with how we diagnose it. And it also, if we think about it, the directionality of those beliefs has a lot to do with how we then approach doing something about it. So why is this something that we care about so much? Well, because these are people coming in with these beliefs and these responses and reactions to things at a time of life when they have to interact with other agencies inside and outside of their normal sphere in a way that they never have before. So just, we're in a situation where just as people need care the most, they're the most resistant to receiving it. So when PTSD and end of life come together, there can be some pretty significant challenges. And if you look at this, just at the time that I really need to be able to work with my family and work with care providers and social supports, one of the primary things pushing me is this desire for isolation and detachment. Um, I need to sit down and be able to look at my life and start to go through the process of resolving unfinished business. But all I really want to do is avoid. Avoid. And that means these things stay out there. You need to communicate with and, work with doctors, care providers. Oh man, anger and mistrust of, you know, society and especially things that are supposed to quote unquote help me. No way. So we can see that people who are carrying large burdens of trauma many times are going to be reacting to the things that we're trying to do in ways that are not anticipated and certainly aren't very helpful to what we're trying to achieve. We talked a little bit about some of the kinds of situations that can result in trauma and PTSD, but there are lots of different kinds of experiences that can potentially produce moral injury. And I just wanted to go through a couple of them because I think that'll give you more of a sense of the kind of directionality that we're talking about. So again, I think just the idea of betrayal um, overall in trauma is one of the most powerful factors. And if we're talking about betrayal by others versus betrayal of our own, that has a lot to do with that directionality that we're talking about. But let's say that I've been ordered to break the rules of engagement, or perhaps I feel a rush of excitement in the midst of combat or killing, um, or perhaps other kinds of acts are going on that where the punishment doesn't fit the crime, maybe mistreating civilians or captured enemy combatants, things that inside I know are wrong, and yet I take part in them or I don't stop them. Sometimes incidents involving death or harm to civilians. One of the most powerful is killing children or witnessing or perpetrating violence or abuse of other people. Even within ranks kinds of violence, where the idea is I feel that I have somehow failed to fix or correct the situation. Um, and these are things that can happen in a flash, they can happen in a moment. One of the most powerful that I dealt with a gentleman. He was, what do you call it? Oh, well, it's a LARP. It's a long range patrol person. And so he was basically out on his own with very little cover. And he was caught in an ambush. And through a combination of luck and skill, he was fortunate enough to survive this. But it was several minutes of incredibly intense fighting between him and a group of people. Just as this situation was ending, just as he was starting to feel that he had possibly survived this moment, there was a rustling and some tall grass to the side, and he could see something move, so he turned and fired, and what stumbled out of the grass was a small child. When I met him, this was 45 years later, and the only thing that he carried in his entire life was this idea of what a horrible person he was because of what had happened in that moment. And it was the guilt and the shame from that that had come to completely define who and what he was. And because of the beliefs built around that, it did not allow him to interact very much or very well with other people, whether it's family members or in our case, care providers. So in PTSD, we talked about how the world becomes a dangerous place. In moral injury, we become the danger as we are now broken, unworthy, unforgivable, unredeemable. People start to say things like, I know where I'm going when I die. There's no point to this because it's already been decided. The loss of trust and disconnection leads to a loss of meaning and purpose. And really, there's no other choice but a sense of despair. And here on the slide are just some examples of signs of moral injury that we may well see as we're talking with somebody in a hospice care setting. All right. So what do we do about this? Now that I've got everybody probably feeling really depressed and bad, sorry about that. What a great way to start your day. Let's maybe turn to something that we can do to make things better. And the first thing that I'd like to talk about is just a useful patient-centered approach to address PTSD and moral injury in hospice care that can be applied. And it's this sort of stepwise psychosocial stage model for the end of life. There are 3 stages to it, and treatment really only moves forward to the next stage if symptoms are not resolved and if the veteran would like additional treatment. Now, it sounds kind of fancy and a big deal, but the reality is this is all stuff that really makes sense and we should probably be doing anyway. So the first level is just palliating immediate discomfort, providing social support, and psychoeducation. And the majority, if not, many, if not the majority of issues that we run into can be dealt with at this level because there is incredible power in respect and information. And so it's just simple things like making sure that people know the names of their providers, that they have things to help them orient themselves in time and space, like clocks and calendars, that there are nightlights if they need them, that it's a relaxed environment. Things that seem so simple, but that in care environments are easy to skip over. Things like knocking on doors, asking to come in instead of just stepping in, announcing who and what we are and why we're there, and giving people options. Hey, I would really like to talk with you about this right now. Is this a good time? And then remaining accountable. So if I'm working with somebody and I tell them I'm going to do this, to really do that because they have to have some sense of that talking with me matters, that it's got a real value for them. And then finally, in terms of interventions, probably the key one is just really being present, actively listening, being fully engaged so that people know that you're really listening to what they're saying, providing reassurance, assistance with solving practical kinds of problems. And then a lot of times just education, things that feel pretty basic to us are things that other people don't know or haven't considered. And so sometimes even just these simple kinds of things can be very powerful. I found that at least in the hospital, one of the most useful roles I can have is mediating between medical providers and family members. Um, Doctors, I think, have a lot of a tendency to talk in sort of a shorthand. They want to get things done quickly and move forward. And so many times family members will nod their heads up and down. The doctor leaves, and if you say, so what's your understanding? They have no idea what's going on. And to take a few minutes and go back and just kind of explain, well, this is what happened, and this is what's going on, can have a huge amount of power and impact in helping people feel calm and safe. Speaking of helping people feel calm and safe, there's a thing called the stress first aid model. And this was actually developed in military settings to help service members have a better ability to do self-care and provide peer support to each other. And it's because people tend to do better when they feel safe, when they can calm themselves down, when they feel connected to others, and feel that they can kind of get through whatever it is that they're having to deal with, or they have some kind of a sense of hope that things may get better. I was just speaking with a veteran. I work with an ALS clinic, and I was just speaking with a veteran the other day, and he's feeling very overwhelmed. One of the things that we do here is for our veterans with ALS, we have a program or a process by which changes can be made in their home so it can be more accessible. Doorways can be widened, bathrooms, things so that they can stay in their home longer. But this work is going on, and it was just overwhelming to him. And we were talking about it, and I said, "Oh, okay, so this is sort of like your school lunch tray." He goes, "What?" And now I don't know if you guys are old enough, but when I was a kid, you went to school and your food came on a tray, and whatever was on that tray, you had to eat it before you could go to recess. And he said, oh, yeah, I remember that. And I said, okay, well, this is a school lunch tray. There's some stuff here that you like, some stuff that you don't, but we're just going to get through the tray and then recess is on the other side. And for whatever reason, that clicked. And he was able to laugh and go, okay, I get it. I get it. These are things I just have to tolerate for the moment. But being able to reconnect him with that sense that he could was what it took to get him through to the next part. So how do we do this? What are the objectives of this? Well, the basic objectives are pretty straightforward. We just want to establish a connection in a helpful way. We want to restore their sense of safety, calm and orient them down so that they can, calm them down, help get them oriented, connect them as quickly as we can to social sources of support that they already know, and improve their ability to address their most critical needs and concerns, and then give them some sense of hope that things are going forward. I think it's important to remember that not everybody is equally affected by things that are going on. Oh, did somebody want to jump in? Oh, okay. And so, not everybody needs something to quote unquote feel better. One size doesn't fit all. So this model is very person-centered, and any action that we take really should just be kind of based on what the person is experiencing and what they are telling us that they need in the moment. So the first core component of stress first aid is to check, which really just involves listening, making a connection, asking opening questions that will begin to allow you to understand what's going on, trying to do this in a culturally sensitive way, and then beginning to ask some more deepening kinds of questions to allow you to get some more information to be helpful in a more useful kind of way. There are several different ways to open a discussion with comments or questions, including asking questions like, so what really matters to you? What concerns you the most? What kinds of things keep coming back to you? How have you been feeling since all of this started? I'm not going to read the whole slide to you, but you don't have to use any of these or all of these. The idea is to find ways to begin to get to know the person and then get to know more information on the person's priorities and needs, as well as how those sort of map onto their prior experiences and how they're affecting the person's sense of themselves and their relationships and the world. I will say that in working with veterans, sometimes there are things that we need to be a little bit careful about. And as we start these conversations, we want to be aware of some cultural considerations. These are some examples of communication do's and don'ts. I've noticed, in working with veterans over the years, two that really seem to get a lot of pushback. The first is saying, I understand. Remember, one of the core things about this is that I've been through experiences nobody else has, nobody can understand. So I'm coming into it with this sort of belief system. And if I work with somebody for a while, I can earn the right to say, I understand. It's something that has to be earned. But because that belief is how they come into this, that no one can understand them, if I say that too early, then that just sort of confirms in their mind that you don't really want to hear from them, that you're sort of just checking. It's sort of, when you ask somebody, how are you doing? And they say, I'm fine. It takes on that kind of a flavor. And they see it as a checkout rather than a way to really want to understand what's going on. The second big one is telling people to focus on themselves, which seems crazy because, people are in a really bad spot. Take care of yourself. One of the things that I think is really important to remember is an absolute core principle that is inculcated from day one to make you a good soldier, sailor, Marine, airman, is that you want to be the best possible that you can because at some point the person next to you might need you. And your core responsibility is to be there to take care of the other people around you. In fact, their needs are more important than yours. And that's a very key part of how the military works, right? I'm here in this little unit, this little group of people, and sure, while I'm here to fight, really one of my primary missions is to take care of the other people around me. So if somebody comes in and we say, no, don't worry about them, it's okay, just take care of yourself, this is seen as a violation of that core principle and will just be rejected out of hand. So instead, we always want to try to couch things in terms of conversations of, well, it makes sense to do this because this allows you to function better in this way or this. An example I'll use is, well, why did you do push-ups in basic? Well, I did it so I could get stronger. Well, why did you need to be strong? Well, in case I had to pull somebody out. Right. So here I'm asking you to do some things to help make yourself stronger. Why? So that you can help pull other people out. And even though it's a justification, by being more consistent with those beliefs and those values that people are coming in with, they're much more likely to accept whatever I say next. Another one of the important aspects of first aid, stress first aid, is that you are always person-centered. And so in general, I like to start with more general kinds of questions. Is there anything that still affects you now? And from here, I can start to shape what comes next based on their kinds of responses. And so some examples of ways that I can start to move into that next level when I've, sort of earned the right to begin to ask these kinds of questions is starting to ask the things like, well, do you think you were changed as a result of being in the military? Or, tell me about how you were changed by it. Do you think these experiences are still affecting you today? Do you ever have dreams or nightmares about this? What was coming home like? Is there anything about that that's still bothering you? And again, there are a variety of examples here, but it's beginning to try to get that broader and deeper sense of what their experiences meant at the time, and even more important, how they see those now and how they define themselves in relation to those. So once we've done that establishment, once we've built that connection with a person, then we can move into the core actions of stress first aid. And as I was talking about before, the model is really built around 5 essential elements. The idea of building calm, connecting, some competence that I can, fix things for myself, and then some confidence that I can actually get that done to help limit self-doubt and guilt. And so now what I'm going to do is go quickly through a couple of different slides about each of those kinds of things. So for cover actions, we can have a conversation about how the veteran feels, any concerns that they might have about feelings of loss of control, confidence that they have about being able to get, pain relief, right? Our outpatient clinic is set up in such a way that our nurse practitioners are on one side of the hall and I'm on the other. And so as I'm walking veterans down, frequently I'll say, okay, that side is pain and this side is suffering. And suffering has a lot to do with not just the experience of pain, but the meaning of pain. And one of the things about the meaning of pain is that belief that things can get better or this can be changed in some way, shape, or form. Things like fear of abandonment or maybe even feeling a fear of death, things that we can begin to help understand that feed more that sense of suffering than just the sense of pain. Calming actions, what we do, frankly, what we say is not nearly as important as what the veteran says. And what I found is that, frankly, what they really want to know from us is that we can tolerate being in their presence, that they can tell us these things, they can share these things with us as they're trying to figure out who they are at the end of their lives, that we can be a witness and stand in non-judgment and sort of bear up under that weight. The story that they tell us doesn't have to be true. We don't have to respond to it. We don't have to act on things if they talk about specific kinds of things. It's really about being able to be present in that honest and sincere way that they can see. And if you don't know how to respond to something, then that's fine. Just saying, you know what, I haven't heard that perspective before. I'm not really sure of, how I've never thought of it that way. And if you want more information, saying, this is such an amazing experience or such a different kind of experience, tell me more about this. Help me understand how this is impacting things now and at this point. Connection can have to do with the veteran themselves. It can also have to do with families. I find many times I'm speaking with families about moral injury, what it is, how it can affect veterans at the end of life, helping families find some sense of connection with their veterans again. Many times, people who've decided that they're dangerous, people who've decided that they're broken, will withdraw from family. They're trying to protect the people around them. But now it means that all of these people are trying to come in and figure out who, grandpa or dad or who this person is. And they feel that they've been pushed off to the side for all of these years. And so many times they're feeling this sense of brokenness as much as the veteran is. And I've actually had family members almost get kind of jealous of the fact that the veteran would talk with me about some of these things. And, so this is where I can actually come back and take advantage of some of that culture that we were talking about, where I can say, look, you know, one of the things that we know about veterans is their primary mission is to protect the people that they love. And so telling you about these things would be a violation of that. And so that's why it's easier for them to tell me than to tell you, right? Um, because again, the family's trying to figure out who they are in relation to this. And they may still be angry at the veteran. They may not understand the situation entirely. But if they begin to understand not even so much the details of the experience, but the meaning of the experience for the person in their lives, it can begin to diffuse or redirect some of that anger away from the veteran and maybe toward the situation instead. Okay. Competence. So people come into this and it's not an uncommon kind of thing for them to say, you know what, I'm dying. I've never done this before. I don't know how to do this. How do I do this? And being prepared to have this conversation, to have a conversation about death and dying, how they want to choose to die, what their models of death and dying are. And, for a veteran who may feel like they don't know how to talk with their family about this, about who or what they are, the sense of moral injury, how all of this makes sense as they're moving toward death, to have a conversation that focuses on how that moral injury has affected them in their relationships and how it's affecting them now. And again, providing them a pathway where they don't have to talk about the details of any events. Rather, they can really focus on more the impact of that on who and what they are and how it's affected their relationship with family members over time. So just some quick suggestions on how to increase rapport and confidence in situations where it can seem like the person really is expressing reactions to moral injury. You know, I try very hard not to do or say things that can be perceived as disrespectful. Never trying to downplay a responsibility. If they're trying to say it's my fault, trying to be reassuring can actually be seen as sort of downplaying that role. Uh, Instead, really trying to stick with more simple, straightforward, non-judgmental kinds of statements. I can understand why you're feeling this way, given your strong values. Uh, you know, what can I do to help? What would be helpful? um, Talk with them, connect them to people who've dealt with similar things, um, help that person construct a trauma narrative that has room for personal strengths and positive relationships, um, you know, anything that is sort of helpful to them, and work with them to examine where, having values is a double-edged sword, right? It can be a guiding principle, but it's also a limiting kind of thing. And so there are times where the principles I live by make my life easier, but there are also times where the principles that I live by make my life harder. And helping them see both sides of that and how having strong values um, has fed into positive actions and choices that they've made as well. And then, frankly, one piece of this is one of my favorite things about palliative care in general, that even in medical settings, we have lots of little teeny conversations. We don't have to solve the world in one 5-minute conversation. I can come back and I can talk with you again and again and again. And I think in a lot of ways that's very helpful for me as a clinician because I don't feel like there's pressure to save the world in 5 minutes, right? I can come back and we can just let each conversation cover the territory that it needs to. And by continuing to come back and continuing that conversation, it also lets them know where your level of investment is and that they can continue to have that conversation with you. So again, we just want to be careful about statements that imply judgments, or can be perceived as accusatory. I don't know, we can sort of see these kinds of things or just, pull yourself up, whatever it is. Again, the situation may not be what we think it is, and any disrespect or judgment conveyed can kind of damage that sense of relationship. So I think just trying to be aware of our own stimulus value in these conversations is an important consideration. Confidence actions. So, here, the idea is building up their sense that they can do something, that they can have independence in what's going to happen next. So talking about strengths, vulnerabilities, about the values that they bring. I think a lot of times emotional pain that I see really is an echo of these core values. The reason I feel bad about this is because I'm violating something that really matters to me. And so this conversation about core values can then help us even more directly come into conversations, about the guilt or shame that they're feeling. They may have an act of omission. They didn't stop something. It sounds like you're sad about this. You're sad about something that you didn't do. Tell me why that's so difficult. And I also think it's very important if we get into a situation and we find we can't tolerate this, um, to be honest about it. Saying something like, I don't know if I can hear this story, but I know somebody who can. Um, Again, that sense of genuineness and realness for that person is going to matter more than just about anything else. And then connect them with somebody, maybe like a VFW or another veteran or somebody like me. And we can sort of move into the next step of it. The last step of this is something that I don't think gets nearly enough attention. The stuff that we do is insanely hard. Um, it's emotionally demanding, it's emotionally draining. One of the things that I do is I train psychiatry residents in how to do psychotherapy. And it's hilarious because they'll come in and they'll tell me, I had no idea that this could be so hard, right? They're like, I go home and I'm exhausted. And they only see a few patients because it's a little training clinic. And it's really easy to just skip over the things that let us take care of ourselves. So just really practical self-care strategies, pacing ourselves to the extent that we can. I think for a lot of us, having some kind of a buddy system, somebody that we can talk to, someplace that it's free to have, or at least more free to have a bit of our own escape valve, to take a little relaxation break if we can. Um, just before this started, I was listening to Greg Porter, one of my favorite jazz singers, because it's a way to just sort of get myself into a space that works better. And I think just being aware of our own limitations, our own needs, and honoring those allows us to again come back with fresher eyes and a greater ability to take care of the people that we take care of. So that's pretty much everything I had to say. You guys were pretty quiet, so either my cat woke all of you up and you're all asleep as well,